Hello, my name is Sarah Aker. I'm the Deputy Director of South Dakota Medicaid, and I'm going to talk a little bit about Medicaid today and Money Follows the Person and our Recipient Handbook. So Medicaid at its core is pretty similar to an insurance program. Medicaid was founded in 1965 under Title 19 of the Social Security Act. We've also implemented in South Dakota the CHIP program, or the Children's Health Insurance Program, in 1997. Medicaid is an entitlement program. That means that regardless of how many people are eligible, all of those people have to be served. So if there's 10,000 people or 110,000 people, we have to serve everyone who meets the federal and state requirements for the program. Medicaid provides health coverage for low-income children and families who lack access to private health insurance, as well as people with chronic illnesses or disabilities. Medicaid is a federal-state partnership. I'll talk a little bit more in depth about what that means and how that kind of plays into Medicaid in a little bit. States each administer their own Medicaid program. We have a saying in Medicaid that if you've seen one Medicaid program, you've seen one Medicaid program. That makes it kind of challenging sometimes to compare states side to side or side by side. A lot of times we get questions or comments that, oh, when I lived in Iowa, I got this service, or when I lived in North Dakota, this was the program. Each time we tell people, well, that was in Iowa, that was in North Dakota, this is South Dakota, and this is how we administer our Medicaid program. The other thing I always like to point out is that Medicaid is not Medicare. Medicare is an entirely federally administered program and is specific to individuals who are over age 65 or who are disabled and meet the federal disability criteria. However, someone can have both Medicare and Medicaid at the same time. Because Medicaid is more of a financial eligibility-based program, we do see a lot of individuals that have both Medicaid and Medicare. We often call or refer to them as dual eligibles. So one of the ways that Medicaid is a federal-state partnership is in how the state finances Medicaid. So funding is shared between the state and federal government, and that takes the form of the FMAP, or the Federal Medical Assistance Percentage. In federal fiscal year 18, and the federal fiscal year runs from October 1st through September 30th, the Medicaid FMAP for South Dakota is about 55% federal funds and 45% state funds. So what does that mean? It means that for every dollar we pay out in Medicaid, 55 cents of that is federal dollars and 45 cents comes from the state general fund. Every 1% change in the FMAP is attributable to about $7 million. So in terms of kind of how Medicaid plays into state budgets, it's definitely a big component of the South Dakota budget. There's a couple things to note about the FMAP. The FMAP never goes below 50%, so the state is never obligated to contribute more than 50 cents on every dollar, and it generally doesn't go above 80% either for the Medicaid program. There are different programs, though, that do have different FMAPs. The CHIP, for example, has a different FMAP, and it also has been inflated by the ACA. The FMAP for CHIP is about 91% federal funds and 9% state funds. There's also certain services that have a different or enhanced FMAP. So, for example, services that are provided directly by Indian Health Service or through Indian Health Service are eligible to be reimbursed at 100% federal funds. We also have certain services like family planning services, for example, are eligible for 90% federal funds. Also on this slide, you can kind of see how the state FMAP has varied by years. We've kind of hovered right around that 50% mark, which is good news for South Dakota because it means we're doing well economically. But definitely that state FMAP has the potential to really change the state's budget every year. We also really like to talk about who we serve when we talk about the Medicaid program. Our program is predominantly kids. If you look on the slide here, about 68% of our population is children. The other 32% of adults fall into just a couple categories. So the majority of those are age blind or disabled adults. Most of those adults are served through an HCBS waiver like the Choices waiver or the Hope waiver. We also cover pregnant women as well as low-income parents. The Division of Economic Assistance within DSS performs all of our eligibility determinations, though they do that with assistance from the waivers to get level of care from those specific programs when a level of care is required in addition to financial eligibility. I always like to talk about the 2017 or the federal poverty guidelines and what those look like. As you can see, we've kind of put our eligibility groups up on the top and then the associated annual income. It really varies for kind of depending on what type of eligibility program you're talking about, where they fall on the FPL guidelines. So kind of at the top is the Children's Health Insurance Program. We cover kids in that program up to 209% of the federal poverty level, which is right around $52,000 for a family of 4 in a given year. On the other end of the spectrum, parent and caretaker relatives of low-income children is the group that has the lowest threshold for financial eligibility. That group is covered at about 52% of the federal poverty level, which isn't actually listed on the slide below, but would equate to about $13,000 a year for a family of 4. I also always like to show this slide that kind of shows you on the left-hand side the amount of enrollment that's attributed to a certain group, and then on the right-hand side, the expenditures also attributed to that group. So even though kids are our largest population, covering kids is relatively cheap. They only account for 35% of our expenditures, even though they make up 68% of our population. On the other side of that spectrum are age-blind and disabled adults that even though they account for relatively small numbers of our population, the care for this group is definitely our most expensive care. It's usually because these individuals have multiple chronic conditions, potentially they have really high needs because of their disability or because of their age. And really when we talk about kind of solutions that can help reduce Medicaid expenditures, it's usually this group that we're looking to focus some of those efforts on, predominantly because they have a high spend. So in state fiscal year 16, Medicaid covered about 147,000 people in a given or during the year. But because Medicaid eligibility is income-based, there's people who come on and off the program during the year. But in any given month, we have about 118,000 individuals. So what does that really mean? Well, nearly 1 in 7 South Dakotans in any given month has health coverage through Medicaid or CHIP. When we look at kids, 1 of every 3 children under the age of 19 in South Dakota has coverage through Medicaid or CHIP, and about half of all kids born in South Dakota are on CHIP or Medicaid during their first year of life. So when you're thinking about Medicaid or CHIP, you know, you might not think that you know somebody who's on Medicaid or CHIP, but chances are that you probably do, just given the breadth and the scope of the population that we cover. So the other area where we see that federal-state partnership come into play is in regulations. So the Social Security Act is the regulation that governs Medicaid and CHIP, Title 19 for Medicaid and Title 21 for CHIP. When Congress makes changes to Medicaid authority or Medicaid statute, it's the Social Security Act and these titles that they're amending through that legislation. The other area where we see federal regulations come through is in the Code of Federal Regulations, or CFR. CFR defines kind of the mandatory Medicaid benefits and populations that states have to cover, but they also provide options for states to elect to cover and that they can receive federal funding for. So that's one of the areas where states can really choose what their program looks like, is in that optional services category, and where you see the most variation from state to state. Changes in CFR can require a state to make changes. So if the federal government makes new rules in a certain area, that can cause our state to have to change our regulations and or administrative rules as well. The other area where we get guidance from the federal government is through state Medicaid directors letters, and sometimes they're called state health official letters. This is supplemental guidance from the Centers for Medicare and Medicaid Services, or CMS, that really include their policy interpretations. So this is telling us how they've interpreted a particular section of the Social Security Act or CFR, and kind of what states have to do to be in compliance with those federal regulations. So Medicaid in South Dakota is governed predominantly by our Medicaid state plan. This is the contract between the state and federal government describing how South Dakota administers the Medicaid program. It's really interesting reading. It's about 700 pages long if you're looking for something to read at night when you want to go to bed. But a couple key points about it are that it designates the Department of Social Services as a single state agency for overall administration of the Medicaid program. That basically means that DSS has oversight of all Medicaid dollars that are spent in the state. Amendments to the state plan can reflect federal or state changes in the Medicaid program. So some examples of that are if whenever the state legislature passes inflation for providers, that requires us to amend our Medicaid state plan to account for that in our payment methodology. There's also state plan amendments that come as a result of coverage changes or because the federal government has made a policy change that requires us to make a plan amendment. There's a pretty formal process for making changes to the state plan. We first go through a public notice and tribal consultation period of 30 days. Then we submit that state plan amendment to our regional office, which is in Denver. The regional office does a preliminary review and then sends that state plan amendment on to the central office in Baltimore for a more thorough review. At that point in time, they have the ability to ask us questions kind of informally, or they can initiate an approval, disapproval, or formal request for more information process. If you're curious, the state plan amendment or the state plan can be found on the DSS website at the link on this page. We also have other kind of rules that govern the Medicaid program in the state, probably the majority being found in Administrative Rule of South Dakota. This is another area where we implement federal and state legislative mandates or changes. And this is probably a more specific area and contains specific limits on amount, duration, or scope of services. So for example, federal CFR gives us the option to cover vision services. It lets us cover eyeglasses or things like that. In our state plan, we say, yep, we do cover vision services in South Dakota. And then in administrative rule, we get pretty detailed and we say, yes, we cover vision services, but only every 18 months when a lens change is medically necessary. So it really kind of drills down the further into these regulations that you go. The other place where we have kind of some regulations for providers is our state billing and policy manuals. And this contains specific information about how providers are expected to bill a claim. It also contains kind of supplemental information from those other regulations resources that providers need to know in order to process a claim appropriately. So I like to show this slide about our Medicaid services. Each state is required to cover certain services. There's a select listing of services that are required to be covered by every state through their Medicaid program, but then states have the option to cover services in addition to that. So some examples of mandatory services are things that you'd expect, things like inpatient and outpatient hospital services, nursing facility services, services provided by physicians or rural health centers or federally qualified health centers. And then some of the optional services are also some things that you think, well, I always like to point out prescription drugs as an optional service. Technically it's optional, but every state in the nation covers prescription drugs. Other things though I like to point out is dental services. Most states limit dental services. A lot of states don't cover dental, or if they do, they only cover it for children. South Dakota does cover it though for both children and adults. So what does South Dakota spend on Medicaid? Well, total Medicaid expenditures were just about $900 million in state fiscal year 16. We're vastly approaching that $1 billion mark. The Medicaid budget is one of the largest parts of the state spending, but it does cross budgets for several state agencies. So predominantly a lot of that budget is located in DSS as the single state Medicaid agency, but then a lot of those services are also located at the Department of Human Services that administers our HCBS waivers. We also have services that we pay for in conjunction with the Department of Health. For example, when someone goes to a Department of Health clinic for a vaccination. We also provide services for some kids that are in the custody of Department of Corrections. Medicaid is a payment source for the state vet's home in Hot Springs. And then we also pay for services in schools and the Birth to 3 program at the Department of Education. So this slide breaks that down a little bit more to tell you a little bit more about what South Dakota spends on Medicaid and kind of where those dollars are going. So one of the biggest expenditures in Medicaid is institutional-based care. So hospitals, nursing homes, those really take up a large part of the budget. As you kind of go down the list, you'll see other services such as our community support providers in the choices waiver, as well as physicians, IHS, and pharmacy claims. So I want to spend a little bit of time talking about what the Division of Medical Services at DSS does. One of the things we're required to do under federal regulation is enroll providers. We're not actually able to reimburse claims for someone until they're an enrolled provider. So we have a group of folks that work on provider enrollment and ensure that all of our providers meet all of the federal and state standards to enroll in Medicaid and are made an eligible provider. So they're checking federal databases to make sure that that person is alive, to make sure that person has never committed Medicaid fraud in South Dakota or in another state, they've never committed Medicare fraud, and they do that process for each of our 15,000 enrolled providers. South Dakota also operates its own claim processing system. In state fiscal year 16, we processed just about 5.3 million claims and answered approximately 90,000 phone calls from providers. We have a telephone service unit in our division that answers those calls and processes those claims. We also have quite a lot of focus on program integrity in Medicaid. The Surveillance and Utilization Review Unit, or the SURS unit, is a federally mandated review process that kind of looks at claims post-payment. What they do is look for trends in Medicaid billing. They look to see if a provider is suddenly billing differently than they have in the past or billing more than they have in the past, and look to see if there's any kind of trends that they can dig into that might be attributed to provider fraud. We also have a quality improvement organization. We utilize the South Dakota Foundation for Medical Care to review inpatient hospital claims to ensure that we are having quality of services and also that hospitals are correctly coding everything that happened in the hospital on the claim form. The Office of Recoveries and Fraud Investigations is actually part of the Division of Finance in DSS, but this division conducts investigations of recipient fraud. So they're looking into making sure that someone has, for example, when they became eligible, told us about all of their bank accounts, told us about all of their resources. They're also making sure that recipients aren't utilizing their services inappropriately. They also, however, do make payments or recovers payments from third-party liability sources. I'll talk about this a little bit later on, but Medicaid is always the payer of last resort, which means that all other kind of sources of payment are required to pay before us. So that means Medicare, if someone has private insurance like Dakota Care or Blue Cross Blue Shield or Avera Insurance or Sanford Insurance. Even if someone's, for example, in a car accident, there's often liability for the driver or the insurance company associated with that car accident, and the Office of Recoveries and Fraud Investigations will investigate those types of situations and recover third-party payments. In terms of kind of our policies and programs, we have a primary care case management program or PCCM program. This is where recipients are able to pick or select a primary care provider. If they don't select one, then we assign one to them that is responsible for providing most of that person's primary care. They coordinate services for that recipient and often refer them on to specialty sources if they need it. About 80% of our Medicaid population is required to participate in that program, and that includes children, low-income families, pregnant women, and certain disabled recipients. For the most part, individuals who are served by an HCBS waiver are exempt from that program. I'll talk a little bit more about our Health Homes program later on as well, but this program is one that we implemented in 2013 to really provide services to individuals in Medicaid that have chronic conditions, so multiple chronic conditions. They either have 2 chronic conditions, or they have one and are at risk for another, or they have certain behavioral health conditions that qualify them for the program. These individuals are usually, some of our high needs, high cost individuals. And so we've designed this program to reduce their inpatient hospitalizations and ER visits, and also increase the integration in between primary care and behavioral health services to really make sure that that individual is getting the best possible care. This program serves about 6,000 Medicaid individuals a year, and we successfully avoided about $5 to $6 million in state fiscal year 16. We also have a team of nurses in South Dakota Medicaid that process prior authorizations for services. We require prior authorizations for services outside of a 50-mile border surrounding South Dakota, as well as for other certain high cost or certain services that we want to more closely manage. Those nurses also track inpatient hospital utilization. So when someone's been in the hospital in South Dakota for more than 6 days, hospitals are required to notify our staff of that, and we assist with discharge planning or connecting them to other sources of care that they might not have thought of as part of the discharge process. We also have a couple things related to pharmacy management in our program. So our Pharmacy and Therapeutics, or P&T committee, is a group of physicians and pharmacists that meet quarterly to review pharmacy utilization, and then they also recommend some management practices to us, including prior authorization for certain drugs. Along those same lines, we also have a drug utilization review committee, or the DUR committee, that conducts a retrospective review of recipients' drug claims and provides education to physicians. So what they're doing there is really looking for people who might potentially be getting medications from multiple sources, and maybe inadvertently or accessing drugs in a manner that might be risky to that person or might constitute risky behavior. I'll talk a little bit more about the Medicaid Recipient Handbook later on as well, but each recipient, when they become eligible for Medicaid, receives a Medicaid Recipient Handbook. It's also available online and in all the DSS local offices. If you encounter a Medicaid recipient who has not seen your recipient handbook or who doesn't have one, please get them one. You can order them online or just pick one up in a local office. It contains really important information for Medicaid recipients about their program policies and benefits. A little bit later on in the presentation, I'm going to talk about the 5 things that, if you have a spare moment, you should definitely consider mentioning to Medicaid recipients. So Medicaid waivers are a method for a state to test kind of a different way to deliver and pay for healthcare services. There's a couple of rules about Medicaid waivers. We can't waive the basic tenets of Medicaid, so we can't just, take the federal dollars and say, nope, we're not providing healthcare. We can't cap overall Medicaid enrollment, so we can't say, oh, we're only going to serve 100 people in Medicaid in South Dakota. And the other thing we have to always prove is that it has to be cost or budget neutral, so it can't be more expensive than the traditional way of providing care. However, Medicaid waivers can vary from existing kind of federal Medicaid requirements in certain areas. We can provide access to different services or services that aren't typically covered under Medicare or Medicaid. We can also restrict kind of who's eligible for those services, so make them have a certain level of care, and we can restrict them to just the population that's served. There's a specific process to obtain waivers. It requires a pretty detailed steps of negotiation between the federal government and the state, including an application for the waiver, and then a series of negotiations. The process is pretty similar to the state plan process. Kind of one of the difference being is that it happens before the waiver is implemented versus the state plan is kind of an ongoing process. One category of waivers that is pretty well utilized across the nation is HCBS waivers, or home and community-based services waivers. This is really a way for states to focus on recipients that might otherwise be served in a medical institution. The aim of these waivers is to keep people at home in a community-based setting, as opposed to more expensive care that takes place in an institution. We have 4 HCBS waivers. All are operated by the Department of Human Services. The first is the HOPE waiver, which you should be familiar with, as Then the Assisted Daily Living Services waiver, the ADLS waiver, is operated by the Division of Rehabilitative Services. And then the Choices waiver and the Family Support waiver are operated by the Division of Developmental Disabilities. Each of these waivers has a level of care associated with it and services that are provided through the waiver that aren't available usually to the rest of the Medicaid population. CMS also has an option for states to provide research and demonstration project waivers. This provides some flexibility for states to test new approaches or evaluate kind of an experimental policy that kind of delivers from traditional ways of paying for Medicaid. This can do things like expanding eligibility to people that aren't otherwise Medicaid eligible, or providing services that aren't typically covered, or creating kind of a new system delivery program. We have one demonstration project, and it's called Money Follows the Person. And I thought I had some slides about Money Follows the Person, but it turns out I do not. I'll tell you a little bit about the Money Follows the Person program instead. So prior to Money Follows the Person, there was a pot of money given for nursing facility care and a pot of money given for service in the community, so that like an HCBS waiver, for example. But there wasn't money to get the person from the nursing home to the community. And that's really where Money Follows the Person comes in. So MFP is responsible for taking someone who's been in an institution and transitioning them to the community. So really looking at ways that we can, or benefits we can provide that will allow that person to live independently at home instead of in a nursing facility or an institution like the Developmental Center in Redfield. Oftentimes we find that, people maybe went into the institution. When they went into the institution, maybe they had an accident that resulted in them having a significant disability. Maybe now they're in a wheelchair. And the reason they can't go home, they've gotten better, they've done therapy in the institution, but now they're ready to go back home, but there's no ramp to their house, and they have steps up to their house, and they literally can't get in the door. Or potentially maybe they need some doorways widened because now they're in a wheelchair and their wheelchair doesn't fit through the walls of their house. So that's where Money Follows the Person can really provide some assistance. So they can do things like build ramps or make home modifications while that person is still in the nursing facility before they move out of the nursing facility. They also do things like if someone needs a place to live, maybe they had a home or an apartment before they went into the nursing facility, and then since they lived in the facility, maybe their furniture got sold, or maybe they no longer have a place to live, but they could live in the community if they were able to. So that's an area where we can provide some assistance with a rent deposit or with furnishing some basic goods and services to that individual, maybe buying their first month groceries or paying for their utilities to be connected. That's typically how we see services provided through the Money Follows the Person program. We have an MFP coordinator. Her name is Sarah Spisick. She works out of the Sioux Falls office, and she's the one that intakes kind of Medicaid referrals for Money Follows the Person and determines if they're eligible for the program. So to be eligible for MFP, someone has to be at least 18. They have to have lived in an institution for 90 consecutive days. That could be a combination of days in a hospital and a nursing facility, or an institution and a hospital. It really just has to be 90 consecutive days. That individual has to have one Medicaid paid day in that facility. So they don't have to be eligible for Medicaid the whole time they're in the institution, but they do have to be eligible for Medicaid at least one day prior to their transition out of the facility. That person also has to be willing to and want to be served by a HCBS waiver after they transition, so the HOPE, ADLS, Choices, or Family Support waiver. And they also have to want to live and receive services in the community. So we can't force someone to leave the nursing facility using MFP. They really have to want to be part of that process and want to live in the community. Once someone transitions through Money Follows the Person, MFP continues to be able to provide services to them for a full 365 days following their transition. However, we found mostly that once an individual goes out into the community, that they really are able to be served fully through our HCBS waivers. So that's a really positive of our HCBS programs, that they're able to really meet the needs of these people in the community after they've left the nursing facility. So now I'm going to talk a little bit about the Medicaid Recipient Handbook, more specifically about the 5 things that you could highlight for a recipient and that we think are really important for recipients to know. So the first is preventative care. We just added this section to our recipient handbook, and we're really excited about providing some more information about what preventative care is eligible for or available for Medicaid recipients. Most Medicaid recipients have some form of preventive care available to them. The type or coverage may differ by program, so how they're eligible for Medicaid. But for full coverage adults, we really recommend that they get their yearly checkup or screening with a physician. That could include things like a BMI assessment, a cholesterol screening, blood pressure. It might include, for women, a well woman's exam or a pap smear. But it also lets that individual talk with their doctor about their health questions and kind of what services might be appropriate for that individual. We really recommend that everyone gets their annual wellness checkup once a year, and we do cover that for adults once a year. We also really recommend that individuals take special note of dental care and making sure they're getting in for their yearly dental exam and cleanings. South Dakota Medicaid covers 1 dental exam and 2 cleanings every year. Well, 2 dental exams actually. And there's a list of services they can that are eligible for Medicaid recipients to receive. We also cover eye exams and immunizations for adults, as well as cancer screenings. And so any medically necessary preventive services, we always encourage people to talk to their physician about what services are right for them and make or take steps to get preventative care. The second area that we really like to focus on in the recipient handbook is payment of medical bills. So like I said earlier, South Dakota Medicaid is the payer of last resort. All other coverage must pay before Medicaid. That means if someone has Medicare, that claim always has to be submitted to Medicare before it can be submitted to Medicaid. The other thing I like to talk about here is that non-covered services, things that aren't covered by Medicaid, are the responsibility of the patient. So it's really important for the patient to know what those services are and to ask their provider if the service is going to be covered by Medicaid. One other thing of note is that Medicaid payment is considered payment in full. So whenever Medicaid has paid on a claim, that means that the recipient is no longer obligated to pay for any part of that service. So even if Medicaid pays 0 on a claim, so potentially maybe Medicare paid a claim and Medicaid paid what was left, but turns out Medicare paid more than Medicaid would have paid, and so we paid 0, that means the payment is considered payment in full, and the recipient is not obligated to pay for those services. So some things to talk about here with recipients, or things to emphasize, is to make sure that the provider always knows and has the recipient's Medicaid ID number. Providers can only bill Medicaid if they know the person has Medicaid, and so it's really important for a recipient to be showing that card every time they receive services. We often get calls from recipients who cannot prove or didn't show that they showed their Medicaid ID card, and they might be receiving a bill from the provider because the provider didn't know that they had Medicaid as a payment source, and providers have a limited amount of time that they can bill Medicaid for services. We require providers to bill Medicaid within 6 months from the date of service. So if a service was provided in January, we ask that provider to bill us by the end of July for that service. If they don't bill us within that time frame, then we deny the claim for what's called timely filing. However, if the timely filing wasn't able to be completed by the provider because of the recipient never told them they had Medicaid, then in some cases the recipient can become responsible for those services. Which brings me to our second point, is to not ignore medical bills. Mistakes happen. Sometimes the provider didn't know you had Medicaid. Sometimes they wrote your number down wrong. A variety of things can happen that could cause a provider not to bill Medicaid and to bill the recipient instead. All too often, though, what happens is that people ignore medical bills. They throw them away. They say, oh, I've got Medicaid. Medicaid covers this. I don't need to pay attention to this. And then, you know, a year or two passes and then they're sent to a collections agency. And by that point in time, it's often too late for us to fix whatever error might have happened. So whenever someone gets a medical bill, we'd encourage them to open it, to contact their provider and let them know to bill Medicaid, or to call Medicaid. We have a recipient liaison, and her number is listed in the Medicaid Recipient Handbook that individuals can call to ask questions to. A third area to emphasize in the Recipient Handbook is for out-of-state services. So we require recipients to get prior approval for any services that take place outside of a 50-mile border around South Dakota. Some things to note here is for recipients to wait to make their travel plans until they have approval. We do not cover services that are not approved, so it's really important that recipients not go to their appointment without receiving the okay from South Dakota Medicaid that the service has been approved to be covered out of state. The reason we cover or do prior authorization services for services received out of state is we're really looking for a couple of things. We're looking, A, is the recipient going to the closest place? So are they going to, are they hoping to get a service done in Minneapolis? That could be done in Sioux Falls, and if it can be done in Sioux Falls, we ask that recipient to get that service done in Sioux Falls. We also just need to know where services are being done outside of the state. So maybe it's a service that isn't available in South Dakota, but our recipient's asking permission to go to, let's say, New York City, when the service could be done at Mayo Clinic in Rochester. We're always going to try to have our recipients go to the closest source of care so that they can really be as close to home and able to get back to South Dakota. There are some exceptions to the out-of-state services prior authorization. Services within a 50-mile border around South Dakota and in Bismarck, North Dakota do not need prior authorization. And then certain lab, radiology, or pathology services, DME, and pharmacy services do not need prior authorization either. Also, if someone is out of state and there's an emergency, out-of-state emergencies are exempt from the prior authorization process as well. I talked a little bit earlier about our Health Homes program, but I wanted to emphasize it again. This is a program that provides care coordination for Medicaid recipients with complex or chronic conditions. The Health Home program provides 6 core services. So we'd encourage recipients, if they're eligible for the Health Homes program, to review the information about it in the Recipient Handbook, and also contact their healthcare provider to talk with them about if Health Homes is right for them. We'd also encourage them to write down the contact information for their health home so they can call them with questions or to better understand the health care they're receiving, and to also know what services need a referral. The 5th section of the Recipient Handbook that I'd really recommend digging deeper into is the Covered Services section. Coverage of services can vary depending on if a recipient has full Medicaid coverage or limited Medicaid coverage. And also, not every service is covered by Medicaid. Services not covered or in excess of South Dakota Medicaid limits are often the responsibility of the patient. So for example, you'd want to point out potentially the $1,000 dental limit for adults. So adults every year, every state fiscal year, are subject to a $1,000 limit for services. That limit does not apply to emergency services or to dentures, but it is something that someone might want to be aware of when they're going to the dentist. Additionally, things like new glasses are only covered every 18 months. We always encourage recipients to ask South Dakota Medicaid or their doctor if a service will be covered if they are unsure, so they can know ahead of time if they might have to pay for a service. I also like to emphasize that recipients can be reimbursed for travel to medical appointments outside their city. So for example, if someone lives in Pierre and they need to see a specialist in Sioux Falls, if they drive themselves or maybe they have a family member that drives them to the appointment, they can request reimbursement through non-emergency medical travel or NEMT for mileage and in some cases also lodging or meals, depending if the trip required overnight travel. So that is it for my presentation today. There's lots to know about Medicaid, and if you ever have questions, feel free to contact me. My information is on the screen. Send me an email or catch me by phone, and I'd be happy to answer any questions you might have. Thanks.